So we're going to start off. So just before we begin, Zaheera, I'm just going to introduce quickly. So welcome everyone to our Fireside Chat. Today is Fireside Chat number 197. And we have got Dr. Cassimjee, who is going to take us through lupus nephritis treatment update. So before we hand over the mic to her, I would just like to briefly introduce her. She's a specialist physician and a consultant nephrologist with experience in both public and private sectors. Currently, she's working in private practice at Netcare St. Augustine's in Durban. She has a MBChB and MMed, both at cum laude and fellowship in nephrology. She's widely published researcher in kidney disease, dialysis, and lupus nephritis. And she's an accomplished educator and speaker with experience teaching postgraduates and presenting at local and international nephrology forums. So without further ado, Dr. Cassimjee, the floor is yours. Thank you.
Thank you, Mazhar. Thank you for the very kind introduction, and thank you for the opportunity. I'm just going to switch my video off for bandwidth here. Okay, so we are going to look at some of the updates that have been made at lupus nephritis. We'll look at what's new in the literature. So with a particular focus on the updated KDIGO 2024 lupus nephritis guidelines. So since the 2021 glomerular disease update from KDIGO, there's been so much research and novel therapeutic agents that have been studied that they found...
Sorry, just to interrupt you, apologies. Yeah. For some reason, your screen seems quite shrunken. I'm not sure what happened there. Initially, it was fine.
Yeah.
Initially, it was fine when we first tested it, but it seems like it's shrunken quite a bit and there is some sort of background. Not sure what happened there.
Let me try sharing, stopping share and sharing again.
Yeah, please.
Okay, so we also have a brief look at the American College of Rheumatology guidelines that were also updated late last year. Their last guideline was in 2012, and some big changes have been made in therapeutics, so theirs have also quite radically changed. South African data show that lupus nephritis is the commonest secondary cause of GNs, and that mirrors international data. In those with SLE, the lifetime incidence of lupus nephritis is anything between 20 to 50%, depending on the demographics of the population studied. So kidney disease development in lupus is the most important predictor of morbidity and mortality, especially for patients that progress to kidney failure. The ultimate goal of treating lupus nephritis is to preserve kidney function while minimizing immunosuppression-related toxicities. So this pathogenesis, this slide, I know we're all very familiar with. SLE involves a complex interaction between genetic susceptibility, environmental factors, and what goes wrong is that there's primarily a loss of immune tolerance and the onset of chronic autoimmunity, which is the initial trigger for lupus. So in SLE, what is impaired is the clearance of dead cells and genetic material. This is on account of apoptosis and netosis defects. So what netosis defects is neutrophil apoptosis defects. And what it leads to is exposure of self-antigens to the immune system and eventual immune complex formation with deposition in the kidney. In terms of some new concepts that have been thought about in genetics and epigenetics and environmental factors is something called the kidney skin axis and the gut kidney axis. So UVB light appears to stimulate neutrophil migration to the kidney in an interleukin dependent manner, which creates a so-called kidney skin axis, which is why covering up from the sun is so important for patients with lupus. And other factors that have been implicated are the gut-kidney axis. Leaky gut allows pathogenic bacteria to enter the bloodstream, stimulates the formation of antibodies and immune complexes which deposit in the kidney. And then genetic association. So there's more than 100 susceptibility loci, there's racial disparities, and the strongest genetic association relates to MHC region. So what hasn't changed is the threshold for doing a biopsy still remains at about 500 milligrams of proteinuria, or if there's any unexplained reduction in EGFR or any glomerular hematuria. So those are the reasons that we would do a biopsy in lupus, much lower thresholds than in other diseases. And the classification of lupus is the one that we're all familiar with, class 1 to 6. And over the years, there's been several criticisms of this classification. including that it is glomerulocentric. It relies heavily on findings on light microscopy and not the underlying pathogenesis of the disease processes. It also doesn't adequately consider certain compartments of the kidney, such as the tubular interstitium, vascular lesions, podocytopathies, and TMA. As a result, a group of nephropathology experts met and proposed a revision of this classification, and the immediate aim was to improve problematic definitions that form the basis of the lupus nephritis classification, and thereby increase the inter-observer agreement. As you can see in this graph, concordance between pathologists across the board was quite poor, which obviously has implications for management. So this part of this classification has been replaced by the modified NIH activity and chronicity scores that have replaced the active and chronic 4G and 4S. And particularly the 4G and S showed poor inter-observer variability between pathologists. A score more than 2 requires treatment. Following on from this, there's an increasing body of evidence that says that the importance of tubular interstitial damage requires more emphasis. The old classification has been criticized for focusing predominantly on glomerular lesions, and it seems like tubular interstitial lesions better predict renal survival. We can see in this table that the degree of interstitial inflammation and interstitial fibrosis correlate with both the risk of end-stage renal disease and mortality, and being as high as 57% end-stage renal disease and 24% mortality in the red group that you can see. And so perhaps we should be looking more closely at the tubular interstitial component of our biopsies, and greater weight should be attributed to it in the lupus nephritis classification. Also, if we look at our biopsy reports and read them critically, if we see there's a lot of tubular interstitial involvement, perhaps our immunosuppressive strategy also needs to change and maybe be a bit more aggressive. So in terms of management strategies, all patients with lupus nephritis effectively have CKD, and this increases their risk of cardiovascular manifestations as well as secondary immunodeficiency. So to minimize the risk of CKD progression, we need to focus on both arms, not only just the immune arm, but the non-immune factors, which I'll talk about in the next slide. And then we can see suppressing autoimmune activity in the bottom graph. Suppressing autoimmune activity in lupus reduces repeated episodes of inflammatory kidney injury. So every time there's a flare or not achieving remission, it leads to accelerated decline in kidney function. There is an emphasis in the KDIGO guideline regarding background non-immunosuppression medication. So cardiovascular risk modification is important. Then they talk about infection risk, so vaccinations and prophylaxis should be considered for these patients, especially, in our setting in South Africa. One must always consider PCP and TB prophylaxis. When we look at things like bone injury, most patients with lupus are young females, so issues of pregnancy, being very aware of that in patients, and the immunosuppression that is teratogenic, being aware of ovarian failure as well. And then cumulative doses of drugs such as cyclophosphamide, we must be aware of cancer. And then to go back to the CKD progression and proteinuria, there is a recommendation that on top of maximum RAS blockade, SGLT2 inhibitors should be used in stable patients without AKI. And that's been echoed in the European lupus guidelines as well for patients with a reduction in GFR or proteinuria. And the reason for this, they've shown that SGLT2s in mice that are treated with empagliflozin, it decreased double-stranded DNA, proteinuria, creatinine, and seemed to ameliorate podocyte damage. And what it does is it reduces inflammation and enhances autophagy in the kidney. So it's quite promising. But again, to be aware that patients with lupus are immunocompromised on immunosuppression, and there's always a theoretical risk using an SGLT2 for increased urinary tract infections, etc. Then clinical risk factors for progression in lupus nephritis. So they can be divided into patient factors, biopsy factors, and treatment factors. So at the time of initial presentation, an elevated serum creatinine, uncontrolled blood pressures, heavy proteinuria, certain race groups associated with a poorer prognosis. Then there's biopsy factors. We talked about tubular interstitial disease, interstitial inflammation, obviously crescents, as well as fibrinoid necrosis, and then delayed treatment, failure to achieve a response, and relapses as well. Portend a poorer prognosis. Despite use of these guidelines, outcomes remain suboptimal. Remission is somewhere between 50 to 70%, and 10 to 20% develop end-stage renal disease within 5 years of diagnosis. And this is data from the developed world. In the African setting, late presentation with advanced disease, there's issues with treatment, with access, shows a much poorer outcome. So if you go to the actual classes of lupus, in lupus nephritis class 1 or 2, immune complexes form within the mesangium. It does not usually cause irreversible glomerulosclerosis, and KDIGO suggests that if there's just low-level proteinuria, immunosuppression must be guided by extrarenal manifestations. However, if there is nephrotic syndrome, so if you find a patient with showing lupus class 1 or 2 and nephrotic syndrome, you must evaluate for lupus podocytopathy, which I will chat about. Okay, so usually if you see a patient with nephrotic syndrome and lupus, you would think class 5, but if you get a biopsy back that shows class 1 or 2, you must think about lupus podocytopathy. So podocytes are also a potential direct target to lupus nephritis. And podocyte injury is characterized by foot process effacement and cell detachment. And of course, those two processes lead to proteinuria. So what is lupus podocytopathy? The clinical presentation is usually a nephrotic syndrome in a patient with lupus. And on light microscopy, what you will see is normal glomerular or just some mesangial proliferation. The clincher is that immunofluorescence is negative. You may just see mesangial deposits, but how you diagnose it is that on electron microscopy, you'll see the more than 70% foot process effacement. And it's divided into two entities, a minimal change and an FSGS entity. And like minimal change, it's exquisitely steroid responsive. Over 90% of patients given steroids will respond within a month. But again, like minimal change, relapses are common. So this is something to be aware of for lupus podocytopathy. The most aggressive type is a class 3-4 lupus nephritis. So KDIGO's latest guideline for proliferative lupus nephritis starts off with saying, does the patient do a biopsy and assess chronicity? If there's a lot of chronicity, it's probably more dangerous to give immunosuppression and give supportive treatment for the patient instead. If there isn't, and there's active class 3 and 4 lupus nephritis, the usual next step is glucocorticoids. So it's usually methylprednisone, doses from 250 to 500 milligrams per day for 1 to 3 days as appropriate, depending on your disease severity and rate of progression. And then prednisone, and it says 0.3 to 1 milligram per kilogram, but there's a big move towards using much lower steroid doses and tapering much quicker than what we are usually used to. After you've done the steroids, then there's 4 different options. So the 2 options that we are used to, which is cyclophosphamide and mycophenolic acid, remain, and we'll discuss the 2. And the newer options that have become available are either the addition of belimumab to mycophenolic acid or cyclophosphamide, or a multi-targeted type of therapy with using a CNI and mycophenolic acid on the background of low-dose steroids. Okay, so those are the 4 options that they advocate for. That's what KDIGO says. Now, the American College of Rheumatology is actually quite different and quite radical in their thought of what you should do when you get a patient with either class 3, 4, and they also include class 5 here. And they say that on top of just basic chloroquine and RAS inhibition, you should give all patients triple therapy. So that's steroids. So after a glucocorticoid pulse, you should taper very quickly to less than 5 milligrams a day by 6 months. And then their preference would be mycophenolic acid and either belimumab or CNI. Alternatives to that would include low-dose cyclophosphamide and belimumab. And the rationale for this is that trials have shown that these patients have better complete response, and the adverse effect profile doesn't seem too bad, so it seems like a better option. This may be appropriate for the American College of Rheumatology, but KDIGO does make a note and make mention that cost is very important, and it's clearly not affordable for many, many countries in the world. So it still remains probably more pragmatic to use a KDIGO kind of stepwise approach. So a regimen of reduced glucocorticoids are very much favored, and studies have shown that lower doses of steroids may result in better long-term safety. This is extrapolated from the novel CNI studies like the Aurora one, that voclosporin, where after high-dose steroids, the The next dose of steroid they used was about 25 to 30 milligrams after initial induction. And the patients seemed to do well. So we can see here that by week 11 to 12 in low dose steroids, the steroid dose is already 5 milligrams compared to what we normally used to. This is quite promising because we all see a myriad of steroid side effects. Patients are also reluctant to take steroids because of this. So the choice of induction agent is class B across the board, class 1B across the board. So why would you choose certain ones over the other, apart from what you have in your armamentarium in your hospital? So anecdotally, cyclophosphamide is still chosen by many physicians for patients where kidney function is rapidly deteriorating or whose biopsy shows severe activity, in that it shows necrosis or lots of crescents. It should be noted that there are very sparse data on this group of patients who present with aggressive disease, as this kind of clinical characteristics excluded them from most clinical trials. But we know cyclophosphamide is favorable in patients with severe extrarenal manifestations. We tend to use them where compliance is an issue. But we are aware of both acute and chronic toxicity and fertility issues in the majority of patients that are younger females. Then there's MMF. So we choose it maybe if a patient has a high cumulative cyclophosphamide use before, facility costs, where they don't want to, and quality of life, where someone doesn't want to come in for infusions. And the ARMS trial showed that the ethnicity played a factor with MMF, so that may change why you would use MMF over cyclophosphamide. And then kidney transplant clinical trials show that compared with an MMF dose of 2 grams a day, an increased dose of 3 grams a day did not result in a higher efficacy, and that was in the non-Black population, but it was associated with more adverse effects. So again, dosing is something that we must think about. And then belimumab, possibly favored for patients that have a high risk of progression and lower proteinuria. And I say lower proteinuria because it seems like there's increased clearance of belimumab when the proteinuria goes above 3 grams. And then CNI use. Usually the trials have shown that it's in patients with relatively preserved renal function, so GFR more than 45 mL per minute, heavy proteinuria, and it's done well in most of the Chinese patients that were studied. The heavy proteinuria is based on just how CNIs work, which we will chat about. So the first regimen that we talked about was cyclophosphamide, and there's 3 options to give cyclophosphamide. It can be high dose, which is the NIH regimen, which is 0.5 to 1 gram monthly for 6 months. The Lupus, which is 500 milligrams every 2 weeks for 3 months. But bearing in mind, initially, this Lupus showed equal efficacy to the NIH, but it was mainly tested in a Caucasian population. However, emerging data suggests that low-dose cyclophosphamide is effective in multi-ethnic patients, but these studies, however, didn't make a direct comparison to high-dose IV cyclophosphamide. And then there's oral cyclophosphamide, and of course, the cumulative dose is higher in these patients. So all in all, between 3 regimens, reduced dose IV cyclophosphamide has the most favorable immediate toxicity profile among the 3 cyclophosphamide regimens. And again, all the things to think about: compliance, extrarenal manifestations, aggressive disease versus the toxicity, fertility, the malignancy risk. So trials of MMF for initial treatment of proliferative lupus nephritis have targeted dosing of 2 to 3 grams a day. And I said that several studies have shown that MMF has comparable short-term efficacy to that of oral or IV cyclophosphamide for induction. Bearing in mind, MMF has significant gastrointestinal toxicity. So the ARMS trial showed that there was similar incidence of side effects between MMF and cyclophosphamide. And we said through the transplant population, a dose of 2 grams a day versus a dose of 3 grams a day may not have a better effect, but may have less adverse events if you use a lower dose. And then there's CNIs. So the CNIs that are suggested are the usual tacrolimus and cyclosporin, as well as the novel CNI voclosporin. So when you would use a CNI is if someone has preserved kidney function, because you shouldn't use it with the GFR less than 45. If they have nephrotic range proteinuria, because it works well on proteinuria. And patients who can't tolerate standard mycophenolic acid or are fit for cyclophosphamide-based regimens. So how CNIs work is immune mediated. They reduce interleukin transcription, and we know that from transplant, and decrease lymphocyte proliferation. But what they also do is they have a direct modulatory effect on the podocyte cytoskeleton. So what it does is that it prevents phosphorylation of synaptopodin, and because of that, it stabilizes the actin cytoskeleton of the podocyte and therefore reduces proteinuria because you're having the stable podocytes cytoskeleton, and podocyte injury is ameliorated in that way. So this new voclosporin is the new potentially best-in-class CNI. It's been shown to have a more predictable pharmacokinetic and pharmacodynamic relationship. It doesn't require therapeutic drug monitoring. It seems to be more potent than cyclosporin, and it has a better metabolic profile compared to legacy CNIs. So this was the Aurora 1 trial, and essentially what it looked at, there was superior efficacy of voclosporin compared with placebo in patients with class 3 to 4 to 5 lupus nephritis. So similar adverse events, but better renal response. So here they not only do they look at UPCR, which is you expect that to decrease on a CNI, but they also show that the GFR was stable, which is good to know because CNIs have nephrotoxicity. So this one was stable, and it says no rescue treatment. So the dose of prednisone didn't need to be increased while you were on the drug. And patient received background MMF and tapered steroids during this. The limitations of this study is, some would say there was no difference in the serological and the overall disease activity, and whether this is immunological remission or pseudo remission of proteinuria, whether you'd get rebound proteinuria on stopping the treatment, because it's all these non-immune mechanisms. But having said that, it was not only a UPCR decreased use, but there was also a stabilization on GFR, and there was no increased steroid use. So the renal efficacy is considered quite robust. So data are also required on the incidence of acute and chronic CNI nephrotoxicity. Those are ongoing questions regarding CNI use. Can we just use it across the board? What about this nephrotoxicity that we see in transplant? What about the metabolic side effects of CNIs? What about the effect on blood pressure control in these kind of patients where we are trying to ameliorate CKD progression and we want good blood pressure control? And then there's the question about, is there going to be rebound proteinuria after stopping the CNI? And this concept of pseudo remission because of the non-immunosuppressive effects of the CNI on podocytes. So Aurora 2 looked at an additional 2 years of blinded therapy versus placebo, and it showed sustained reduction of proteinuria with voclosporin, similar to other CNIs. There were no concerning safety signal. There was no improvement in the GFR over the 3 years, unfortunately, but there was also no deterioration, which is something else that can be looked at as a positive light. And then the next drug, or the last drug in the options, is belimumab. So a triple immunosuppressive regimens where they use belimumab with steroids and either MMF or low-dose cyclophosphamide. And they may be preferred in patients that have, a more aggressive disease, so repeated kidney failures or at high risk for progression to kidney failure. So belimumab, or B lymphocyte stimulator, BLyS, is involved in the pathogenesis of lupus nephritis. The binding of BLyS to B cells, you can see in this picture, increases their survival and promotes maturation and differentiation towards autoantibodies. So we don't want that to happen. Belimumab is a recombinant human monoclonal antibodies, and so it inhibits the soluble form of BAFF. It prevents activation of BAFF receptors, and what it does is it inhibits B cell survival and maturation, which is what we want. Okay, so it reduces B cell mediated immunity and the autoimmune response. This was the BLyS lupus nephritis trial, 448 patients. They were either giving placebo and standard of care, or there was addition of belimumab. And what it showed was that both partial and complete renal responses were improved in the patients that received belimumab compared to standard therapy alone. And sorry, go back to one, yeah. And then what they also showed over time, this was a secondary analysis, And what they showed that the GFR decline and lupus nephritis flares were also reduced. So unlike the CNI voclosporin, where the GFR was stable, the GFR actually improved. And most importantly, the risk of lupus nephritis flare was lower during in those patients who received belimumab. So we know that every flare that a patient gets causes increased damage in the kidney, which we don't want to happen. So when you compare these both drugs, the complete renal remission increased with both voclosporin and belimumab. At study end, the GFR was similar in the voclosporin group compared to the placebo, but was increased in the belimumab group. Renal flares were similar in the voclosporin group, and they decreased in the belimumab group. Adverse events increased in voclosporin, so it's infection, hypertension, decrease in eGFR, but they were similar in the belimumab. But obviously, in our setting, the cost is probably prohibitive for most places in Africa. So what happens to most patients with lupus nephritis? At 6 months, only 10 to 40% of patients achieve complete renal remission or response. Up to 50% of patients with proliferative lupus nephritis relapse following reduction or cessation in immunosuppression. 20% achieve complete histologic remission, and we've said relapses predispose patients to additional kidney damage and progression to end-stage renal disease. So ongoing treatment is therefore needed to consolidate initial responses into more complete and sustained responses. So the controversies that we all face in clinic all the time is how long do we continue maintenance therapy? Is there a role of repeat renal biopsies, and what do we do for relapsing and refractory disease? Lupus nephritis flared. So we see in this KDIGO guideline, they recommend that after completion of initial therapy, patients should be given mycophenolic acid for maintenance. And that was based on trials that showed that MMF-treated patients had much less flares than azathioprine-treated patients. The other option, so MMF is first choice in KDIGO, and other choices to consider is patients who receive triple immunosuppression as initial therapy. You can continue with maintenance triple immunosuppression, so either belimumab or CNI in addition. In cases where there's no access to mycophenolic acid or it's not tolerated, azathioprine is an option, and CNIs are also an option. So, we always think about the pregnant patient or what you can use in them. Those are the options. So for logistic and economic reasons, most clinical trials evaluate responses at 6 to 12 months. But outside of this formal clinical trial settings, this work group suggests that if a patient is improving, you allow 18 to 24 months to achieve a complete renal response. And that should be reasonable. And these are in patients who are showing continuous improvement. So the complete response is technically defined as a reduction in proteinuria to less than 0.5 grams per gram, and also a stabilization or improvement in the kidney function, and this is within 6 to 12 months of therapy. A partial response is reducing your proteinuria by at least 50% and less than 3 grams. Again, a stabilization of kidney function, and no kidney response is failure to achieve either of these outcomes. Favorable kidney outcomes. So favorable kidney outcomes are predicted by normalization of complement levels and a reduction of proteinuria after about 8 weeks of treatment. But we use the 6 months as a good, even 4 to 6 months as a good indicator of how the patient will respond. Okay, so the total duration of initial immunosuppression plus combination maintenance immunosuppression should be at least 36 months. And the aim is preventing relapses and preventing flares, because we know flares predispose to CKD. The American College of Rheumatology extends this and says that the duration of immunosuppressive therapy for people with lupus nephritis who achieve a complete renal response should be something closer to 3 to 5 years. So in these patients that are on maintenance immunosuppressive therapy, when should you stop the immunosuppressive therapies? There's a study done called the Think to Untreat strategy. So 96 patients who responded to initial therapy, they had low proteinuria, below 0.5 grams a day for 2 to 3 years. They had two arms. Either immunosuppression was discontinued over 3 months or continued, and they were observed for 24 months. The study was underpowered, but after 2 years, there were more severe SLE flares and a trend towards higher renal relapses in the discontinuation group, which you can see here. So there were much higher flares and renal relapses in the discontinuation group. For a long time, it was assumed that a complete clinical response is equal to a complete histological remission, and several studies have shown discordance in patients who have undergone protocol biopsies in this maintenance phase. A major risk factor for flare during withdrawal of immunosuppression is ongoing histological activity. So it was postulated that a renal biopsy done after a prolonged period of quiescence could inform a decision about whether to discontinue or continue maintenance immunosuppression. The flip side to this is patients that have stable partial renal remission and no extrarenal lupus activity. So we see these patients in clinic that have ongoing proteinuria and receive immunosuppression indefinitely. And we know there's obviously side effects and issues with receiving immunosuppression indefinitely. Renal biopsy in these patients have shown that many have no histological activities and actually in histological remission. And persistent proteinuria may be from past injury and scarring. So continuing treatment may put such patients at risk for infectious morbidity and have little benefit for the lupus nephritis. And so this is pushing for repeat biopsies if you are uncertain. There's a proposed de-escalation plan in this Think to Untreat paper that was published in KI, and that says if you've treated for more than 3 years, you have stable kidney function, the UPCR is low, you have no extrarenal manifestations, there's no pregnancy planned soon, there's no history of previous relapses, and there's no risk factors for relapse. Then you do a repeat kidney biopsy. If it shows histological remission, then you start to wean. So you wean the steroids down, and then you wean things like the MMF. And you do this, they suggest, over a year, the tapering. Hydroxychloroquine is maintained long-term, and you monitor retinal toxicity. So that's, one thing to think about when how long to continue maintenance therapy. What about relapsing disease? So KDIGO says lupus nephritis should be treated with the same initial therapy used to achieve the original response, which is fair. Having said that, if you've given cyclophosphamide in the past, you need to calculate lifetime exposure. If patients relapse during pregnancy, treatment choice is obviously more limited, and also patients' preference, tolerance, adherence of the initial regimen. Disease activity should be verified because we know proteinuria may be secondary to CKD, and a repeat biopsy is quite important. And that assesses both the activity and the chronicity in the kidney, and that informs treatment decisions. What about refractory disease? So patients with refractory lupus nephritis have poorer outcomes. Even, you can see in this table, even partial remission is associated with significantly better outcomes. That's in terms of patient and renal survival. There's no remission at all. Suggested algorithm for refractory disease, it's illustrated in the slide. So first things first is adherence should always be evaluated, a repeat kidney biopsy to distinguish active lupus nephritis from scarring or to identify any new lesions. For persistently active lupus nephritis, for instance, if MMF was used for induction, consider switching to cyclophosphamide and vice versa. And then obviously there's the other regimens that also can be used. And then in patients that are refractory for first-line regimens, the addition of rituximab or other biological therapies, extended courses of IV cyclophosphamide, and clinical trials if they're eligible. So every patient needs to be individualized. So while we're talking about rituximab, we'll just look at the B-cell therapy that is currently available. So rituximab use in refractory lupus nephritis continues, and that's despite the outcomes of the LUNA trial, which also had a lot of its own issues. It's primarily based on observational evidence, especially in patients who have inadequate response to first-line induction regimen. And it's still used. There's criticisms of LUNA, and in that rituximab didn't adequately deplete B cells. And when they did high sensitivity flow cytometry for the patients that received rituximab for the LUNA study, more than 50% still had circulating B cells. We know B cells are present not only in the peripheral blood, but they're also present in places such as the tubular interstitial compartment of the kidney. So here, the question posed in this article was that does the speed, duration, or degree of B cell depletion matter? And the answer is yes. So you see the patients that had complete depletion of CD19 cells by a year, that was achieved much better complete renal response compared to the patients that had incomplete depletion of CD19. So the criticism of the LUNA trial was that there was incomplete B-cell depletion. What about other B-cell depleting agents? So to address this concern, a trial of B-cell depletion in lupus nephritis was being repeated with obinutuzumab. So what it is a type 2 chimeric anti-CD20 monoclonal antibody, and it causes more complete peripheral and lymphoid tissue B-cell depletion than rituximab. So the Nobility trial looked at obinutuzumab versus standard of care, similar to the LUNA, how it was done when the obinutuzumab was given. And the post hoc analysis showed that obinutuzumab delayed the time to a lupus nephritis flare and an unfavorable kidney outcome, and attenuated the decline of the eGFR compared to placebo. And so it's been received FDA designation for lupus nephritis. So Nobility served as a foundation so that was the first trial, that was Nobility. Then there was another trial called Regency. So Nobility was a phase 2, Regency is a phase 3 trial. So it served as a foundation for Regency. And Regency kind of looked like Nobility, which also looked like LUNA. And in the Regency trial, patients had to have proliferative nephritis to get in. They had to have a biopsy within 6 months. Half the group got obinutuzumab, the other got placebo, but all received background MMF and steroids. And the oral steroids had to be tapered by month 6. And what it showed, again, complete renal response in obinutuzumab, better than placebo. And UPCR was lower also compared to placebo. What it did show was there was higher serious adverse events in the obinutuzumab. Interestingly, this was done, the adverse events mostly comprise COVID-19 infections. So this was done around the time where there was the COVID-19 pandemic. And then when they look at two halves of the trial, the initial part where COVID was rampant, and then the second half of the trial, once patients were vaccinated, once they got an understanding of COVID-19, the number of patients that developed serious COVID-19 were much less. Okay, so this was in the time, it's not an ideal time to do a study during a pandemic, but that's when they did it. And that's what the adverse events were. And then multi-targeted therapy for refractory lupus nephritis. So this is where tacrolimus is added to background MMF in patients who were refractory. So patients who at 6 months didn't have a reduction of proteinuria less than 2 grams, they added tacrolimus, and they showed significant proteinuria reduction, improved renal survival, and better complete and partial renal response. Okay, so this is also in the armamentarium of patients that are not responding. What about class 5 lupus nephritis? So 10 to 30% of patients with class 5 lupus nephritis progress to kidney failure, and the risk of progressive CKD is associated with the severity of proteinuria. Unlike primary membranous, we say it's a disease of thirds, a third get better, a third stays the same, a third get worse. Lupus nephritis doesn't follow this. So heavy proteinuria does not usually spontaneously remit. And the risk of progressive CKD is associated with this proteinuria. With the heavy proteinuria also comes the other complications of nephrotic syndrome, the infections, the thrombosis, the cardiovascular morbidity. So class 5 has received the least attention in terms of specific clinical trials. The management approach has not materially changed since the last guideline. The ARM study, 60 of, say, the 370 patients had class 5 lupus nephritis. And at 24 weeks, there was no difference in MMF or cyclophosphamide. MMF and PRED seem to be a good first-line agent, and other choices include cyclophosphamide or a CNI and corticosteroids. So that is what KDIGO says. So it says MMF first, but you can choose any of the others. They seem to be reasonable. Again, it doesn't go into much detail about duration. And then comes the ACR, which looked at, again, pure class 5 lupus nephritis. And I mentioned this earlier on, but they are saying that one should treat more aggressively. So you first look at the proteinuria. If the proteinuria is low, then it's chloroquine plus RAS plus steroids and MMF or AZA or CNI. If the proteinuria is heavy, then it's pulse steroids and MMF and a CNI. So it suggests this triple therapy off the bat. And then again, assessing the response in 6 to 12 months. So the ACR guidelines seem to be much more aggressive for class 5 as well. So we've gone through a lot of these new therapies for lupus nephritis. We looked at Aurora 1, Aurora 2, Bliss, Nobility. What we haven't looked at, so the other new drugs are interleukin-17 antibody inhibitors. And the other drug that I will briefly mention is this TULIP lupus nephritis trial, which looked at anifrolumab. And what anifrolumab is a monoclonal antibody that targets the type 1 interferon receptor subunit. It has been approved for SLE without lupus nephritis, and its rationale for using it in lupus nephritis stems from the role of the interferon pathways in lupus nephritis pathogenesis. So over 80% of lupus nephritis patients display elevated interferon gene signatures linked to active disease and treatment resistance. So a central factor in the pathophysiology of lupus, in patients with lupus nephritis, these high gene signatures are associated with active disease, with proteinuria, with treatment failure. And type 1 interferon promotes kidney fibrosis, scarring, formation of immune complexes, recruitment of leukocytes. So it's all in all quite bad for the kidney. And of course, targeting it seems like a good idea. So this TULIP 1 and TULIP 2 trial didn't show good renal efficacy, but there's another trial, TULIP lupus nephritis, which seems to show that over time, there seems to be some signal that complete renal response is improved. And so that's a new drug in the distance that may become useful for lupus nephritis. And this is just a slide for the fellows, the key takeaways from the KDIGO 2024 clinical practice guidelines, looking at the general measures and what to do for induction and maintenance. That's it. Any questions?
Thank you very much, Zaheera, for this comprehensive presentation. I believe you did justice to the presentation and to the disease itself. And just before we go to the questions, I completely agree with you. Most of these drugs are actually not available, at least where I practice. The most we have is cyclophosphamide and MMF, and obviously steroids. The other problem that we also have is kidney biopsies. So they are, again, difficult to access given the cost itself, but also most of our centers, especially the government facilities, do not actually have immunofluorescence, which then makes it difficult to get the diagnosis correct. For those patients who are able to afford, the specimen is actually sent out either to neighboring countries like Nairobi or to India to get the diagnosis done. So there is actually quite a bit of time before you can actually get the right diagnosis for your patient. So these are a few challenges that we deal with. Hopefully, with the ISN pathology fellowship that there is, we probably can get a few candidates to go in and get the pathology done so that we can get better diagnostics done from our side. I'm not sure if you want me to read the questions for you, or do you want to go through the Q&A?
You can read them for me. I'm okay with that.
Okay. All right, fine. So we have got our first question. The person is asking, I have lupus, and for some few months, I've noted foamy urine and protein plus urine in protein plus in urinalysis. Urine microalbumin is 224. Does that mean I have nephritis? I'm on MMF 1,500 milligrams, losartan plus hydrochlorothiazide, atorvastatin, and prednisolone 10 milligrams, tapering to 5 milligrams.
Yeah, given that you have proteinuria, I missed what else was in the urine, and I missed the renal function. But if you have proteinuria that's ongoing on immunosuppression, it's likely that that's having renal involvement is very possible.
Yeah, there wasn't mention of renal function. There wasn't mention of blood in the urine. But I think the person that asked this question probably need to see your nephrologist to discuss the possibility of lupus nephritis, and you probably may need further evaluation for the same. Mariam has your hand up. Let me just allow you to speak. One moment.
Hello, hi, thank you so much. I'm the one who asked you the question. And my UVCs is good. I have protein +1 for my urine, blood +1 in my urinalysis. So I wanted to ask about nephritis because I've not been given a diagnosis of nephritis yet.
It's highly likely that if you're developing that on immunosuppression that you do have nephritis, but obviously I don't know your clinical setting, what extra-renal manifestations you have.
I started this year, April, MMF. I didn't know. Before that, I had misdiagnosis for almost a few years, 10+ years.
Okay, right.
Yeah.
I think it's probably most prudent to see a nephrologist.
Okay, thank you so much. But am I on the right medication? That's what I wanted to know.
It all depends on what your what your lupus diagnosis was based on and what symptoms you had.
Thank you for your question. Prof. Bima, you can unmute and speak.
Thanks, and Zaheera, thank you very much for that very enlightening presentation. That's very well done. Okay, so I just want to bring up one aspect that is, I think from adult nephrology, you are not so sensitized to, but in pediatrics, we are highly sensitized to it. And that is the aspect of immunization in these lupus patients. And the reason I'm bringing it up is, I once gave a patient cyclophosphamide with lupus, and we didn't have varicella vaccine available. The patient developed hemorrhagic varicella and actually demise from that. So we are very sensitized to that. And one of the things that we do is before we start any high dose immunosuppression is actually check on the vaccine schedule, etc. Make sure, hepatitis titers are up, make sure the patient's got pneumococcal vaccine, varicella vaccine, and on all that. So that, if we do start to immunosuppress them, they don't develop one of these overwhelming infections and die. But that was just an aside. The other drug that is, that often is underplayed is hydroxychloroquine. So I think that with lupus nephritis, hydroxychloroquine is very, very useful. What's your take on that? It's cheap and readily available.
So absolutely.
It's not bad.
Strongly across the guidelines, they all strongly
Yeah.
motivate that the background must be hydroxychloroquine. It's definitely underutilized. I'm just bringing you back here to this. KDIGO, does talk about influenza and vaccinations and screening for hepatitis and looking for herpes zoster. And in our setting as well, we've seen you as well have seen patients demise from PCP, TB, etc. And prophylaxis and vaccination is definitely underutilized.
Yeah, something that we don't pay too much attention to, even in our transplant patients. But thanks, that was very nice.
Thanks, for Bima for that question. We've got a few questions. Zaheera, do you have the time?
Yeah, sure. I think we can go till 7.
All right. Okay, fine. So Margaret is asking, are these clients good candidates for transplant in view of relapses?
They have to be free of the disease, has to be completely quiescent. Different people say different things, but 6 months to a year, I would go with a longer time period. And you look at completely stable extrarenal disease as well. I mean, they would be good candidates because you think you're putting the patient on an immunosuppressant. It should dampen down the extrarenal lupus that is around. So quiescent disease before, and it's definitely doable.
And usually these patients with lupus tend to, when they get to end-stage kidney disease, the disease by itself, in a way, gets quiescent.
Turns out, absolutely.
Yeah.
And that's because of things like the kidney being a reservoir for things like the tubular interstitial compartment being a reservoir for antibody immune complexes, etc.
Yeah. All right. We've got a question from Dr. Zoya Adam. She's a nephrologist in Kenya. She's asking what factors guide when you can start tapering glucocorticoids. If lupus class 3-4 at 18 months, RBC in urine and persistent proteinuria of less than 0.5 grams is stable, would you rebiopsy?
So at 18 months, there's proteinuria less than 0.5.
Yeah.
And,
and there's RBC in urines, yeah.
Whether that's change, whether that's dysmorphic, and what the renal function is doing is also important. But if there is some activity in the urine, which you're suggesting, then
Yeah.
you'd be a bit more hesitant to taper immunosuppression. We'd look at things such as the renal function and what's happening with it, and the proteinuria over time as well, and what class of lupus nephritis it is. It's a complex
3-4.
answer. 3-4. So it's a complex answer.
Yeah.
Necessarily only guided by just a dipstick, etc. So what else is happening with the patient? Has there been any change, etc.? Do you think you need to rebiopsy? Is it, is a thing stable? Sometimes, as we we mentioned the proteinuria can be ongoing because of damage, but often, you wouldn't glomerular hematuria shouldn't really just be from old damage. You expect some activity causing that.
Activity.
So you'd be a bit more
Thank you.
cautious tapering. Yeah.
Yeah. Yeah. All right. We've got another question. What's your say on these scoring systems with regards to African setting? I think is it the SLEDI, the BILAG, the SLIC?
So that sounds like it's more of a rheumatology question
Yes.
than a
Yeah,
nephrology.
no, I want to say that, yeah.
To be fair, a lot of this is extrapolated from European studies, as are most of these trials. So
Yeah.
difficult to comment on. Specifically for lupus nephritis, we don't really use them specifically. You just need a little bit of kidney involvement to be called lupus nephritis. Yeah, I am not sure about in an African setting how the SLEDI performs. I'd leave that question to a rheumatologist.
I think it's research questions for us to decide and
Yeah.
see if we can get that answer.
I must say, from our, for all of us working in resource limited settings, a lot of it is clinical based. We're not necessarily, a lot of these forms and scores are for research so that it can be compared from one patient to another across time. They have to have some sort of mechanism that's, you can easily use to compare patients. So, but clinically, the patient before you is what's most important.
Yeah. Okay. A couple of more questions. Michael is asking about commenting on CD19 CAR T cell therapy and any role for SGLT2. I think you've already mentioned the second part, maybe just the first part, the CD19 CAR T.
CD19 therapy would be like B cell depletion with B cell depleting agents, and obviously there is a role for that. We know that. There's definitely a role for that, and we talked about rituximab and the LUNA trial and the problems with the trial, that there wasn't inadequate depletion of B cells, which resulted in not the most favorable outcome, but actually when in the subpopulation that they looked at, that where the B cells were fully depleted, there was a good renal response to that. So definitely there's a place. And then SGLT2s, yes, there's a place for them. I think there's a place for them in CKD, and there's definitely a place for them in lupus nephritis. The KDIGO guidelines, the EULA guidelines, they talk about podocyte, beneficial effects to the podocyte, decreased or increased autophagy, decreased double-stranded DNA. So there's lots of effects that SGLT2s have been shown across the board. So I would say for anyone with CKD or proteinuric CKD, definitely an SGLT2.
Right. Got another question from Alfred. Alfred is a nephrologist in the central region of Tanzania. He did his PhD with Professor Naika at WITS on novel biomarkers. So he's asking a question about any novel biomarkers to predict treatment response and personalized treatment strategies in lupus nephritis.
Sure, they probably difficult to say. Novel biomarkers. But I haven't come across any that are routinely or widely being used. I'm sure if you search for it, you find it, but there's nothing that's widely being used, even in these trials. It's actually back to the basics. And as simple as predicting renal response after 6 months of therapy, that's going to tell you a lot about how your patient's going to do or what happens to the proteinuria, the GFR, etc. Those are important stops for deciding on therapy. But in terms of widely accepted novel biomarkers, not specifically in terms of monitoring treatment. Of course, if you're using things like B-cell depleting agents, you're going to look at, that kind of thing.
Mm,
But,
mm.
we also don't have access to most of this. I mean, if you're saying you don't even have access to renal biopsy, it's extremely difficult to treat these patients.
Yeah. All right, thanks, Zaheera. A couple of more questions, if you don't mind. It is, as you see, a very hot and interesting topic. So we have got another question from Oswin. Oswin is a final year nephrology fellow here in Dar es Salaam. So he's asking, in a patient with lupus nephritis on cyclophosphamide 750 milligrams monthly, has received 6 doses. Her protein has reduced to 0.7 grams with stable eGFR. She has not attained remission after 6 months, but she's improving now after 6 cycles. Can we add more cycles so as to attain remission or switch to another treatment plan?
Sorry, you said 750. Do you mean 750 milligrams of cyclophosphamide?
So she's received 750 milligrams IV monthly
Of
for 6
cyclophosphamide.
doses. So it's,
Yes.
yeah, so 6 doses of 750.
What is the proteinuria?
So it's reduced to 0.7 grams and not
Okay.
0.5.
What
Yeah.
did it start off with?
Maybe I can ask Oswin to unmute. He probably is a case that he has. Oswin, I'm just going to ask you to talk, please, so you can ask your question. It'll be easier. Just unmute.
Hello.
Okay,
Good
go ahead.
evening. Yes,
Good evening. Go ahead.
thank you for this opportunity. Yes, we had this patient. So this patient had proteinuria of 3.7, around 3.7. Yes. So she received these cycles. I asked this question because I saw in the presentation, you said in the patients that have not attained remission at 6 months, but have shown improvement. You can continue with treatment up to 12 months if I got it correctly.
Yes.
So as to make sure that the patient attains remission. So in this patient who was receiving cyclophosphamide, so can we continue with more cycles as we see that there's improvement, but not yet reached not attained remission?
So that was referring to, so the usual induction is 6 months, and that's with whichever drug you're using, and then you go on to maintenance. I'd be hesitant to use repeated doses of cyclophosphamide. I'm not sure what your PCR was when you started, but 0.7 is not bad. It's one of the trials. It's classified as a partial efficacy renal response. So the patient has responded to some degree. I must say, you could go to maintenance therapy with MMF and see how they do. It is not necessary that you continue giving there's issues with giving the cyclophosphamide, the high dose induction therapy. That's why induction therapy is for a short time. It's not for 12 months because we're giving these very high doses. So you sort of, you're doing a NIH regimen, and that was capped at 6 months generally. I would probably give maintenance, and then if the patient relapses, then you can consider, if the cyclophosphamide worked, you can give it again at some dose. But I think it does sound like there's been a renal response, definitely a partial efficacy renal response. And, we don't expect a complete response at 6 months. That is being a bit too ambitious. So even if you consolidate with MMF, you're still giving immunosuppression, and you continue it for the 2 to 3 years, and you see how the patient does. Obviously, you monitor the patient in between. If there's flares and they responded to cyclophosphamide, at that point, I think you could go back there.
Oh, okay, thank you.
Thank you, Zaheera. Another question from one of our fellows, Anna, is asking, in comparison to the KDIGO dual immunosuppressants versus ACR guideline on triple immunosuppressants, which one is more recommended in refractory and relapsing disease?
So they are going with the ACR is going with sort of off the bat triple immunosuppressive to get a better response overall. Refractory is sort of it's different. It's refractory or relapsing. You then, if you've done one, you try another. Theoretically, you should have better response if you give triple, and that's adverse effects aside. You should have better response if you're giving triple, and it's shown that with the studies that they do have good response. But relapsing, and we say relapsing, you often go back to what you used before, but refractory, then you start thinking of other drugs and monoclonals like, 19 depletion, etc. So of
Yeah.
course, I would say triple therapy would probably do better, but we are all resource limited. So that's ideal practice. That's why,
Yeah.
cost is not an issue. That's probably what you should be using. But
Mhm.
so we're going with the, yeah, that's what my answer would be. They probably, of course, will do better if they're getting more immunosuppression.
Yeah.
And then I say refractory, and refractory is slightly different. You've tried this treatment, and then you try more intensive treatment like CD19 antibody, depletion.
Okay. All right. One last question, Zaheera, and then we should be done. With regards to disease activity follow-up, what's your opinion on, number one, home use of urine dipstick for proteinuria checkup? And two, after how long and why should the renal biopsy be repeated?
So home use. So we mentioned again, if you're in remission and you've never had, and your proteinuria is completely gone, it's something reasonable that you could check, I suppose, to see if it comes back. But then if you have lupus nephritis on treatment, we mentioned that proteinuria doesn't always equal to ongoing activity in the kidney. Sometimes it is scar, and you just get CKD, and you just get a leaking of protein. So it's not, unfortunately, that's why we have to rebiopsy at times, because the proteinuria doesn't tell us all the time what it's from. So I think the first question to answer, if you have quiescent lupus nephritis, if it's gone and your urine is normally clear, I suppose it's reasonable. You could check dipsticks, and if it comes back, you'd be worried. But in a patient, sorry, the second question was, when should you ask when you
Yeah,
rebiopsy?
after how long? Yes, yeah. After how long and why should you rebiopsy?
So you should rebiopsy if there's a sudden deterioration that's not responding, and you think that the class has changed or become more aggressive for whatever reason. Now, suddenly you think you've got a TMA on board, or there's something else that's more severe, or your class 5 has changed to class 3, 4. So then, if the clinical picture has changed significantly and the patient has deteriorated, then you rebiopsy. And then we said the other place for rebiopsying, again, in an ideal world where you can get biopsies, and the ideal place would be when you're considering tapering or stopping immunosuppression. So there was a whole list of things, such as the patient has had less than 0.5 grams for 3 years, there's no disease activity, they're not planning to be pregnant, there's no other markers of flare such as low C3, etc., and you want to stop immunosuppression. That could be a place where you rebiopsy to see that your lack of proteinuria is equal to histological remission. So that's another place that you could consider rebiopsy. And then it's a slow taper thereafter.
Yeah.
So there's different places for rebiopsy, clinically appropriate.
Thank you so much, Zaheera. We do not have any more questions. We're actually about 15 minutes off the time. But it was a great presentation.
The other question, so somebody asked me biomarkers. I'm just remembering them. There are novel things that can be used, that I've come across, but nothing that's available to us. Cytokines, chemokines, interleukins, and the things that have been studied are like interleukin 10 and 17. And then there's other diagnostic biomarkers that have come up, like TWEAK and NGAL, and they're not necessarily all specific for lupus nephritis, but sometimes they can show that there's something going on.
All right. Thanks, Zaheera. It was a nice presentation. As you can see, there's quite a bit of engagement. There was a time that we had almost 130 participants, and until the end, just before we concluded all the questions, there were still about 95 people that were still on. So it was quite interesting and quite engaging. And I thank you very much for taking your time and again doing justice to the presentation and to the disease. And this is something that we see quite often, despite the challenges that we have. We try our best to try and at least save those kidneys as much as we can. Most of our patients come in crash landing, and it's difficult to assist them at that time. But yeah, slowly and steadily, I think we'll get there. So yeah.
Not really. Just to say thank you to Dr. Zaheera. It was quite an insightful topic and discussions. Also loved the questions that were coming in and how you responded to them. So looking forward to other future sessions. Thank you.
You're welcome.
Absolutely. Thank you so much, Zaheera, and I wish you a good evening. Hope to see you again soon.
All right. Thank you. Bye-bye.
All right. Thanks. Bye. Bye.